Hi, this is Zachary Crawford with Pharm EDU, here to discuss acute coronary syndromes, or ACS. Now, in terms of ACS is a result of plaque buildup in the coronary arteries that impedes blood flow. If ruptured, this plaque can then cause a clot formation and sudden reduced blood flow to the heart, aka ischemia. This ischemia leads to cardiac muscle cell death. As these cells die, they start releasing muscle protein markers called troponin, which are then measured, pretty early, approximately 2 to 12 hours and up to 14 days after heart cell death. A lot of the new rapid tests are even more sensitive to troponin levels and can show patients having cardiac muscle death very quickly. Now, risk factors for ACS include age, men over 45, women over 55, family history of smoking, hypertension, known previous coronary artery disease, dyslipidemia, diabetes, chronic angina, lack of exercise, and excessive alcohol intake. Now, ACS includes both non-ST segment elevation, acute coronary syndrome, or NSTE, which then also includes unstable angina and NSTEMI, whereas STEMI is ST segment elevation myocardial infarction. This is kind of the standard heart attack that everyone thinks of. In terms of ACS management or treatment, so the classic symptoms of ACS include chest pain, like pressure squeezing, and lasts more than 10 minutes, dyspnea or shortness of breath, diaphoresis or sweating, syncope, heart palpitations or patients feeling like their heart isn't quite beating weird, and pain that can actually radiate to the arms, back, neck, jaw, and even in the epigastric region, which sometimes patients actually think they're having heartburn or gastroesophageal reflux disease, when in fact they may actually be having a heart attack. So a lot of these patients end up coming to the emergency department thinking that they're having a heart attack, and actually they end up just having some acid reflux. However, obviously you want to make sure that patients aren't having a heart attack, so it's important to come in when patients think that something is going wrong. Now, females, elderly patients, and patients with diabetes may not actually have a lot of these classic symptoms of ACS, and there's a lot of educational towards females specifically in terms of recognizing non-classic symptoms for ACS. Now, any ACS symptoms are considered a medical emergency, and any patients with these symptoms with a prescription for nitroglycerin should plan on taking their dose. Now, nitroglycerin for ACS is dosed sublingually, so you just put it underneath your tongue and it dissolves. You can take one dose every 5 minutes for up to 3 doses. So generally kind of how we recommend people take it is they start having chest pain, they take a dose of sublingual nitroglycerin. If this does not respond, the patient should take another dose and then immediately call 911. And then the third dose can either be administered while they're waiting for the ambulance to arrive, or if the ambulance arrives quickly, then the ambulance can give them their third dose of nitroglycerin. Any patient that has acute STEMI or NSTEMI should really be treated with percutaneous coronary intervention. This is the standard cath lab that we think of, where patients go in, there's an interventional cardiologist, they guide a wire up through typically the femoral artery, and then they can guide that wire into the heart itself and down the coronary arteries, and they can see specifically exactly where the blockages are, and they can inflate a balloon to both improve the blood flow, and they can also place a stent as well. Now, for acute ACS treatment, there's multiple things that also go into it. So we want to use antianginals that are going to decrease the myocardial oxygen demand or increase the oxygen supply or blood flow to the heart. These include morphine, nitrates, and beta blockers. So if we reduce the amount of demand that the heart muscle needs, then it's not going to need as much oxygen, which should hopefully prevent further myocardial cell death. Other agents do include antiplatelets. These inhibit platelet aggregation to prevent clot formation and growth. There's quite a few drugs that can work. Typically, aspirin is one, the P2Y12 inhibitors, and then the glycoprotein 2B3A inhibitors as well. Additionally, there are oral anticoagulants available that will inhibit blood clotting factors to prevent clot formation and growth. So when we think of ACS treatment, we want to think of MONA, GAP, BA. And this is a nice mnemonic that kind of keeps everything in line. So immediate treatment the patient should be receiving, typically in the ambulance, morphine, oxygen, nitrates, and aspirin. Now, once they get to the hospital, we can move in towards the GAP. So these are antiplatelets or anticoagulants that we can use to either slow down the clot or prevent the clot from forming more. And then as we transition to outpatient management, we want to make sure patients are placed on a beta blocker as well as an ACE inhibitor. So any patients that come in with NSTE ACS, we're going to monogap BA plus or minus PCI. Now, if they come in with a full STEMI, you are going to want to do the monogap BA, but you also definitely want to get them to either the PCI, which you have to be at an institution that has a cath lab on call. In patients that present to more rural hospitals that don't have as many staff available, or they don't do PCI, then those patients can typically get a fibrinolytic to specifically break up that clot. Obviously, a PCI is preferred. So, the MONA, the stuff that's giving immediately and as needed. So, morphine, oxygen, nitrates, aspirin. Morphine, this helps in two ways. One, it helps provide pain relief. It can also do a little bit of arterial and venous dilation to allow increased blood flow to the heart. Additionally, it does somewhat actually decrease oxygen demand. Think about it. If you're in a lot of pain, people are typically anxious, their heart's beating fast. If you can help calm down some of that pain, patients will generally be less anxious, which then ultimately turns into less myocardial oxygen demand. It can be given every 5 to 30 minutes as needed. Obviously, cautions include bradycardia, hypotension, and respiratory depression. Oxygen. Typically, at least for anyone in respiratory distress or SaO2 less than 90%. That being said, pretty much everyone that arrives with chest pain concerning for a heart attack, they're going to be placed on oxygen regardless. The nitrates, we talked about that the sublingual dose, it dilates the coronary arteries, it improves blood flow, and it reduces chest pain. You do want to be cautious in patients who have hypotension, as well as those who are using PDE5 inhibitors, whether it's for pulmonary hypertension or for erectile dysfunction. And then lastly, aspirin. All patients should get non-extended release aspirin, either 162 to 325. If patients do take a baby aspirin at home, you can recommend that they just take anywhere from 2 to 4 of those baby aspirins. And then typically patients will be continued indefinitely on a baby aspirin or 2 baby aspirins together, the 162 milligrams per dose. Next, the stuff that's given after MONA once patients get to the hospital. So our options are the GP2B3A receptor antagonists. This includes epsiximab, eptifibatide, and tirofiban, are anticoagulants. So these drugs can inhibit clotting factors and can reduce the infarct size. These include low molecular weight heparins, enoxaparin, dalteparin, as well as unfractionated heparin and bivalirudin. And then our P2Y12 inhibitors, the clopidogrel, prasugrel, and ticagrelor. Oftentimes, these patients are started on at least one of these medicines when they arrive to the hospital to prevent increasing that clot size and reducing the amount of infarct. Next, after the very immediate acute phase, we want to start transitioning patients over to medicines that are going to help them long term. So these are the BA agents that are given within 24 hours and then continue as an outpatient. So 1, beta blockers. There is an increased long-term survival in patients who are taking beta blockers with acute coronary syndrome. So these will decrease the heart rate, the blood pressure, and contractility. This ultimately reduces myocardial oxygen demand, which then reduces ischemia, reinfarction, and arrhythmias. It's recommended you start at the low dose and prefer ones that are beta-1 selective. Typically, metoprolol is generally a go-to agent here. If the patient does have heart failure with an induced ejection fraction, you do want to definitely stick to metoprolol succinate, which is the extended release, bisoprolol, or carvedilol. That's because these are the 3 agents that are only specifically indicated and approved for use in heart failure patients. In terms of ACE inhibitor, these inhibit angiotensin converting enzyme to block production to angiotensin II. They've been shown to prevent cardiac remodeling and reduce preload and afterload. If patients cannot tolerate an ACE inhibitor, they should be placed on an angiotensin receptor blocker or ARB, and generally do not want to use IV within the first 24 hours due to risk of hypotension. Now, in terms of fibrinolytics, fibrinolytics cause fibrinolysis, aka the clot breakdown. They do this by binding to the fibrin and then also converting plasminogen to plasmin. Plasmin itself is what's going to break down the clot. It's part of your body's natural ebb and flow of making and then breaking down clots. So this activates plasminogen to plasmin so that it can start breaking down that clot. These patients are only going to be used in those patients who do have a STEMI. So once a STEMI presents, they're going to get an EKG. Obviously, if a patient is able to be transferred to a place that does PCI within 90 minutes, this is aka the door to balloon time, or within 120 minutes of the first medical contact, obviously if this patient's taken by ambulance. If that cannot be met because either they're too far away, their hospital does not have cardiologists on call and a cath lab available to do the PCI, then at this point patients should be receiving a fibrinolytic. And these should be given within 30 minutes of hospital arrival, aka door to needle time. However, if a STEMI patient is in a situation where PCI is not available and they're still symptomatic, then they can be given a fibrinolytic even 12 to 24 hours after symptom onset. There's 3 agents in this group: alteplase, which is recombinant tissue plasminogen factor activated, so it's TPA. It also comes as cathflow, which a lot of nurses use to restore clotted central lines or indwelling peripheral lines. Tenecteplase and reteplase as well. You do want to keep in mind notable contraindications. These include a history of recent stroke, active internal bleeding, severe uncontrolled hypertension, or history of aneurysms or intracranial hemorrhages, any previous intracranial intraspinal surgery, or trauma within the last 3 months. This is all because if these patients are currently bleeding or have a high risk of bleeding and you give them a drug that prevents clotting, all of a sudden if they start bleeding, you're going to have a really, really big problem. So the biggest thing here to keep in mind and to monitor for is any new bleeding and the bleeding risk as well. Moving into secondary prevention. After patients do have an ACS event, the next step is important to make sure they continue taking their medicines long term to prevent having a second recurrence of this. So 1, aspirin. Really, unless contraindicated, patients are going to be on 81 milligrams of aspirin daily indefinitely. They're a P2Y12 inhibitor, so patients that were fibrinolytic, they're going to get either clopidogrel or ticagrelor with their aspirin for at least 12 months. Patients who received a stent, they can get clopidogrel, ticagrelor, or prasugrel with aspirin for at least 12 months. However, it's also reasonable to extend beyond 12 months if they have a low bleeding risk. They're going to get a prescription for nitroglycerin that they can either use the sublingual tablets or the spray as needed. They're going to be on a beta blocker, used for pretty much at least 3 years, if not indefinitely, if they have a history of heart failure or hypertension. They're going to be on an ACE inhibitor, which is going to prevent that cardiac remodeling, and then potentially even on an aldosterone antagonist for patients with low ejection fractions, or if they have a history of heart failure or diabetes mellitus. And then also a statin. You want to be on a high-intensity statin indefinitely, unless patient is old or over 75 years old, in which case they can be placed on a moderate dose. So in terms of other things to keep in mind, patients who are having aches and pains, they're still going to want to take medicines to treat that. Generally, post-ACS, we want to avoid NSAIDs, especially the ones that are COX-2 selective. So really want to try to stick to Tylenol or even Tramadol if necessary. Additionally, if a patient has a PCI, a stent plus AFib, they're probably even going to be on dual or triple antithrombotic therapy. So they're going to be on potentially a aspirin, a P2Y12 inhibitor like clopidogrel, and then also potentially on an oral anticoagulant like warfarin or some of the new novel oral anticoagulants. If any of these patients have a high risk of bleed or history of bleed, then they're going to be placed on a protein pump inhibitor as well to prevent any worsening bleeding. And that concludes acute coronary syndrome.